Hi, my name is Micah Long. I'm one of the anesthesiology and critical care physicians at UW, and that's a picture of me so you know a face to the voice that you'll be hearing. And today I'll be talking through ventilators, and I really try to think about ventilators, how they work, which is very, very simply. Ventilators are not smart, and most of the time when you hear explanations about what's happening on a ventilator, it's way more detailed than it needs to be. And so I call this talk Thinking Simple. Now, a ventilator doesn't think in terms of modes, and yet for some reason we teach vents in terms of modes. And today, what I'm going to encourage you to do is not think in terms of modes and learn modes, which change names based on the brand of ventilator you're using. But I want you to think in terms of breaths, and ventilators think in terms of breaths. They do not think much about modes. And vents, as they deliver these breaths, put them together to create the modes. And if I could convince you, you only need 2.5 breaths to understand all the modes of ventilation that we use, including APRV. I'll work you through all of those today, but as an introduction, I want to tell you that vents are really simple. Vents deliver either flow or pressure. This picture on the right is a vent delivering flow. And in the case that the flow is fixed by you or by the ventilator, the pressure becomes variable based on the patient. And it delivers that fixed flow for a set amount of time. We call that the inspiratory time. You set that either directly by picking the time or by picking the inspiratory to expiratory ratio and the respiratory rate. For example, if you pick a respiratory rate of 10, you're breathing every 6 seconds. If you pick an I to E ratio of 1 to 2, you spend 2 seconds breathing in and 4 seconds breathing out. And every 6 seconds, that cycle repeats. So you deliver the fixed flow for a set amount of time, and you do that on top of PEEP and FiO2, which I won't really be talking about much today. That's a topic and discussion for another day. And finally, these breaths can be synchronized to the patient or not. They can march on no matter what the patient's doing. In this case, I've not shown the patient doing anything, so it's not synchronized. Vents are simple. Here's the alternative type of breath, a pressure-delivered breath, where a vent delivers pressure, which is then fixed, and pressure turns on like a shark fin. It doesn't go up immediately, but you can adjust how sharp that shark fin is by adjusting something called the rise time, which is how quickly the pressure turns on. So here we've delivered a pressure breath, which means that the flow is variable based on the patient. And we deliver that amount of pressure that we picked for a set amount of time that we pick on top of PEEP and FiO2, and either synchronized or not. Now, if we use common nomenclature or kind of link the breaths to the modes in a simple way, vents again deliver either flow, which would be all of our volume modes with the exception of PRVC, or pressure, which is all of our pressure modes, including PRVC. And they do that for a set amount of time in our control modes. And I'll note that control refers to controlling the inspiratory time. It does not refer to controlling the rate or controlling anything else. It refers to controlling the inspiratory time. Alternatively, the vent can deliver that breath for a set amount of flow percent in support modes, which we'll talk about later on. And it does that on top of PEEP and FiO2, and it can be synchronized to patient effort, which would be assist control modes of ventilation, which include PRVC, and synchronized to the patient in modes like PSV or SIMV, or it can be not synchronized to the patient in conventional modes of ventilation that march on no matter what the patient is doing. Repeating this for emphasis. Vents deliver breaths, and they can do them only 2 ways. They can deliver flow in a fixed way for a set amount of time where the pressure becomes variable based on the patient. It does that on top of PEEP and FiO2 and can be synchronized or not. Alternatively, the vent can deliver pressure for a fixed pressure that you set where the flow becomes variable, doing that pressure for a set amount of time on top of PEEP and FiO2 and synchronized or not. And linking it to the nomenclature, we deliver flow breaths in volume modes, pressure breaths in pressure modes for a set amount of time in control modes. Again, noting that control modes, that word control, refers to controlling the inspiratory time. Or we can turn the breath off based on a flow percent or flow cycling. That's for support and SIMV modes. We do that on top of PEEP and FiO2, and it can be synchronized to the patient via triggers in assist control or pressure support modes, or not in conventional modes of ventilation. All of ventilation can be truly explained by the core concept of V equals IR. And V equals IR is the electricity principle of physics, where V in this case equals the pressure gradient instead of the voltage gradient, and then I equals the flow. But when we look at vent waveforms, which are the drawings I've put here and are on the front face of every vent you'll ever look at, you'll see a pressure waveform and a flow waveform. And that flow waveform gives you mils per second. And if you take that over time, you take mils per second or liters per second times time, you get liters or volume. And so the area under the flow curve, the area in this triangle right here that I've shown an arrow to, is the tidal volume or the total mils of the breath. And then R, the final part of V equals IR, is resistance, or when we talk about the lungs, we normally talk about compliance, and resistance is simply the inverse of compliance. And I'll note that resistance to the vent includes both the circuit, all the tubes and connectors, as well as the patient. And that includes the airway, what we think about all the time, which is the lungs, but also things like the chest wall. And in the chest wall, which is ribs, there are muscles, and we also include work of breathing and effort when we think about V equals IR. So if the patient is using all their muscles to expand their chest wall for you, the vent doesn't have to do that anymore, and the compliance improves with regards to the ventilator. So today, I'll be talking through two things: 2.5 types of breaths, which are all the types of breaths you need to learn today to understand all of our modes of ventilation: traditional control modes, assist control modes, support and SIMV. And I'll just note here that non-invasive modes follow the exact same principles and deliver the same exact types of breaths, but they have different names like BiPAP and CiPAP and things like that. And that's all for today. Now, pressure breathing is how we would describe as physiologic. While I talk, I want you to take some deep breaths through your nose and notice that you are pulling negative pressure from your diaphragm, and you're getting air in through your nose, and that air comes in really quick at the start of your breath, and as your lungs fill with air, that negative pleural pressure is not enough to keep inflating the lungs at the same rate, and the air flow over your nose goes down over time. This reminds me of elementary school when you hooked up a 2-liter soda bottle to a balloon on the inside and a balloon on the bottom, and you could inflate that balloon by pulling the balloon on bottom, which is how you and I breathe, by moving our diaphragm down and putting negative pressure on the balloon. But you could also inflate the balloon by blowing it up from the top, which is how a vent breathes. But the physiology is the same. The transpleural pressure gradient is equal. Both expand the balloon, and so you can think of pressure breaths as physiologic. Okay, so on a ventilator, when you're delivering a pressure control breath, the vent delivers pressure, and that's fixed and set by you. It turns on fairly quickly, and you can make it turn on faster or slower by adjusting the shape of that shark fin there by adjusting the rise time. And when you fix the pressure, the flow becomes variable, and reminding you that the area under the curve equals the tidal volume. You deliver that set pressure for a set amount of time when the vent comes out, and you do that on top of a PEEP and FiO2. And these breaths can be synchronized to the patient or not. Now again, V equals IR drives all of these conversations. And in this case, when the pressure is fixed, the V is fixed, and the flow is variable. And so is the tidal volume. You can change that flow by changing the pressure or by changing the compliance. Now, like I had you take in deep breaths and pay attention to the airflow over your nose, do that again, and you notice that there is a lot of flow and cold air going over your nose at the start of a breath. And as your lungs fill up with air, there's less and less airflow through your nose. That is shown here on the slide with this decelerating pattern of airflow. And you can feel it going over your nose. And that happens because of two main things. The first is that when your lungs are empty, your chest wall is closed or more small. It's ready to expand and very compliant. And as your lungs fill up all the way, your ribs start to push back on your lungs, and your lungs are stretched to capacity, and they are no longer so compliant. So the R changes as you inflate the lungs in the V equals IR equation, and the compliance goes down, so the R goes up and the flow goes down. Now similarly, when you're adding positive pressure to the lungs, at the start of a breath, before you've given anything, the lungs are filled with atmospheric pressure. And as you fill them up with air, they get filled with more and more positive pressure. And so the pressure between the vent and the lung, the delta P or V, decreases. So as you put that positive pressure in the lung, it fills up and up and up, and that delta P gets smaller. And for these two reasons, the flow decelerates quite rapidly in a pressure control mode of ventilation. Now in pressure modes, again, you can pick the pressure and the rise time or the rate you deliver that pressure, and the flow is variable. But you also set the inspiratory time, so you deliver a pressure for a set amount of time, and you can mess that up. So on the left, the breath I've shown is a normal breath, pressure breath. The pressure is circled. It's delivered for a set amount of time, and you see that wonderful decelerating flow pattern. But on the right, I have accidentally increased the inspiratory time dramatically. Well, what happens? V equals IR stays the same. So that initial peak flow looks exactly the same, and the rate of deceleration looks exactly the same. But at some point, the air in the lungs is pushing back at the air in the vent. There's no more pressure gradient, and the amount of pressure from the vent equals the amount of pressure being pushed back on by the lung and the ribs and all those things. And when you have no pressure gradient, you have no V, and of course the I becomes negative. No pressure means no flow. And you get this funny thing called an inspiratory pause, which I've shown with the star here, where the vent is still giving positive pressure, administering it, but there's no airflow happening. So if you do this, it sounds like this. Where you pause at the end of inspiration. Now this isn't dangerous insofar as it causes pneumothorax. You've picked the pressure, and in general we pick pressures that are safe. But it uses all of your breathing time up breathing in. And if you use all your time breathing in, you have less time to breathe out, and you may air trap over time, where you don't have enough time to breathe out all the way. And your lungs will slowly fill up with air, and you'll slowly breathe out less and less and less, and your minute ventilation goes down, and you might get acidotic. And it's also just not very comfortable. So we try to not make that mistake. On the other hand, we can also shorten the I time way too much, shown here. The V equals IR stays the same, so that initial flow rate is no different. The initial decelerating flow is no different, but this time we've cut the breath off really early. And if you remember earlier, I said that that area under the curve is the tidal volume. And in this case, we've cut off the breath so early that we've missed out on this big triangle of tidal volume here. And so to maintain the same tidal volume, you'd have to go way, way up on the pressure to get that pressure waveform or the flow waveform to increase. And it might not be very comfortable because you're going to have a lot of pressure delivered very briefly. And that might not be very good for you. Now, alternatively, if you don't correct the flow or the tidal volume with more pressure, you get a very small tidal volume and a low minute ventilation can result. And that is also not optimal. Now, when you're in a pressure breath style of breathing, the flow is variable based on the patient and that V equals IR phenomenon. So how do we adjust it? Well, there's not many things you set with the pressure breath. You've picked the pressure, the time, the PEEP, and whether it's synchronized or not. And so there's not many things you need to think about to adjust the tidal volume. Using V equals IR, we can see that if we increase the V and the R is the same, the I will go up. So by increasing the pressure, you get a higher flow. And it takes longer to get to that inspiratory pause. So this whole triangle goes up and rightward, making this area under that curve much bigger. And that's the simplest way that we can adjust tidal volume in a pressure breath. You can also adjust the inspiratory time, knowing that if your inspiratory time cuts the breath off here, you've missed out on a lot of tidal volume. And an increased inspiratory time will help you a lot. In the picture I've shown, increasing the inspiratory time would only gain you this tiny little pyramid over here. Not much tidal volume there. And so inspiratory time adjustments are a finite resource. And finally, with V equals IR, we can fix the R, or the compliance. That means we can put in a larger endotracheal tube. This really only matters in pediatric tube sizes. We can suction out the endotracheal tube if there's mucus there, drain water from the tubes, other things like that. Those are small factors. We can help the patient by helping them work with us. If the patient moves their ribs and chest wall for us, the vent doesn't have to, and the vent can move only the lungs along with the patient. So we can decrease sedation, unparalyze, help the patient get stronger, pick the right mode and get them synchronous to the vent, and pick the right settings. And finally, we can help recruit the lungs so that the compliance is as good as it can be. And that can be vent things like optimizing PEEP, recruitment maneuvers, or it can be ARDS things like turning the patient prone on their stomach. Or it can be really simple things like taking an obese patient and sitting them upright so the weight of their abdomen is off of their diaphragm. And finally, you can fix compliance by fixing whatever reason it was that they got intubated to begin with. That was one breath. Here's the half a breath, and it's called a pressure support breath. Pressure support breaths are synchronized to the patient. So here's the star. If a patient takes a breath, they'll pull a negative pressure and a positive flow. Positive flow meaning the air is coming from the vent to the patient. And so they trigger, the breath starts if the patient pulls enough flow into their lungs and out of the vent. And then the vent delivers a set pressure that turns on fairly quickly based on a setting that you can adjust called the rise time. But in this case, we don't pick the total inspiratory time, and the breath turns off not based on time, but based on something called flow cycling. And just a reminder here that the nomenclature of vents is that control modes refer to controlling the inspiratory time. Since you don't hear control in pressure support, we are not controlling the inspiratory time. And they turn off on a set flow percent. Again, we're delivering pressure, the flow becomes variable, and what you see is that you get a decelerating flow pattern, and the vent tracks that flow pattern. It calls the peak flow 100%, or the maximum flow, and it watches it decelerate, and the moment it goes below 30% as a standard setting, the breath stops. That's called flow cycling. Cycling means how the breath turns off. And in this case, it turns off based on how much flow is there. And finally, it does that on PEEP and FiO2. So this is a really nice mode of ventilation because it's very comfortable. If they breathe out or cough in the middle of a breath, the flow will go down. The flow goes back at the ventilator, and the breath will stop, and the vent will not fight their coughing or their breathing out. And they can similarly take a bigger breath. And if you take a really big breath, that flow will go up above 30% again, and they can control their own inspiratory time. Now, we can also help them on the ventilator get a bigger breath, and we can do that in a very similar way as pressure control breaths. We can increase the pressure, fix their compliance, but here we can also change the flow cycling, and we can change it from 30% to 0% and get a tiny bit of tidal volume out of it. We don't normally do that, but some patients are more comfortable with one type of flow breath, either a short inspiratory time at 50% or so, or a longer flow cycling at 10 or 20%. Not very common. That's the half a breath. That's it. The other type of breath is called a flow breath, and I always have nicknamed these Darth Vader breathing. Let me show you why. Flow breaths, and again, these refer to volume modes, with the exception of PRVC, which is not really a volume mode, but some people call it that. Flow breaths deliver flow, and this flow is given at a fixed rate, so it's a square box, and this is why I call it Darth Vader breathing. If you try this out, I'll try to make it loud enough in the microwave. It's a fixed inspiratory rate. And so right at the start of the breath, the flow seems low relative to what you should get. And at the end of the breath, the flow seems high relative to what you get. But it's a very fixed rate, so it sounds like Darth Vader breathing. And these vents deliver flow, so the area under the curve is picked by your tidal volume. Here, if we say pick an inspiratory time of 2 seconds, and a 500 milliliter tidal volume, you give 250 mils a second. And so that area under the curve is easier to calculate. And it does that over PEEP and FiO2. And because we're delivering flow, of course, the pressure is variable. Now, alveolar pressure is quite straightforward. Alveoli are small at the start of a breath, and they're balloons, so they get bigger at the end of the breath. And as they get bigger, the wall tension increases and the pressure goes up. And the compliance of the alveoli will really dictate how high the pressure goes up. If you have a real stiff balloon and you inflate it with air, the pressure will go up more than if you have a very relaxed balloon that's floppy and very compliant. But remember, the vent is a little more complex than that, and we always take into account how much the patient's working to move their chest wall for you. And to this end, the pressure of the vent and the system depends on where it's sensed. We're used to looking at pressure waveforms on the ventilator, but there's a whole lot of things in between the ventilator and at the alveolus. So here I've shown the alveolar pressure. It's easy. You inflate a balloon, the pressure goes up as you inflate it. What you see in textbooks, however, is not an inflated balloon, but this more complex drawing of a peak pressure and a plateau pressure. What does that mean? Well, the pressure is sensed at the ventilator. However, the alveolar balloon is still getting inflated under that waveform. You just can't see it because the pressure sensor is right by you at the ventilator. And there's a lot of things in between the vent and the alveolus. Start at the vent, you have tubes, endotracheal tube, trachea, bronchi, bronchioles, and finally the alveolus. If there's anything in between the alveolus and the vent that is flow restricting, that means it's either small or tight, or that you've used a huge amount of flow. The vent pressure sensor will be high. I think about that like this. If you take a balloon and you try to blow it up through a straw, you have this nice pressure sensor in your face called your cheek. So if you try to inflate a balloon or the alveolus through a straw, which is all the tubes and bronchioles, really fast, your cheek will blow up before the alveolus. And it takes time to equilibrate because the straw is flow restricting. They'll equilibrate eventually, but right away you'll have a blown up cheek before the alveolus has had time to blow up and increase the pressure. So if we look again here, we can see that the peak pressure is very different than what the alveoli sees because it's just what's sensed at the vent if there's something flow restricting in between the vent and the alveolus. The way we talk about that mathematically is a peak to plateau pressure gradient, and the things that increase it are anything, again, that is flow restricting in the middle, like a kinked endotracheal tube, patient biting on an endotracheal tube, a mucus plug or fluid, secretions, gunk in the endotracheal tube. And finally, the one people forget about regularly is bronchospasm. If you have a lot of wheezing and asthma, that's before the alveolus, and it will give you an elevated peak to plateau pressure gradient. Now, that doesn't really matter. You can't rupture bronchioles except in severe premature neonates, and you certainly can't blow up an endotracheal tube with a high peak pressure. So we really care about the plateau pressure when we think about lung protective and safe ventilation. The peak pressure matters insofar as you should think about what is in between the vent and the alveolus that's causing it to happen. So in settings like asthma and bronchospasm, you might track that peak to plateau gradient, and as you treat the patient, it will get lower. But really, when we think about lung protection, the plateau pressure, or what the alveolus sees, is what truly matters. Now, when we fix the flow, the pressure becomes variable, and we can help to optimize that pressure. Normally, what we're trying to do is lower the pressure for a given flow or tidal volume. And there's not many ways to do that. Easiest way, of course, is to decrease the tidal volume. If you inflate the balloon less, there's less pressure there. You can increase the inspiratory time, but really all you're doing is removing flow restriction. If you blow up that balloon more slowly through the straw, your cheek won't blow up as much. And so inspiratory time can help, but it really helps your peak pressure more than your alveolar pressure. And finally, the name of the game in a ventilated patient is to fix their compliance with all the ways we talked about before. Get a bigger tube in, suction the tube, help them be synchronous and work with you. Position them and recruit them optimally. Get their abdomen off of their diaphragm, sit them up. Optimize the PEEP. Use enough PEEP for the patient and treat the underlying conditions. Again, adjusting the time really fixes the peak pressure more than it does any alveolar pressure. Now, vents are smart. These are all computers, and so you don't have to breathe like Darth Vader. On the left, you see a flow breath delivered as a Darth Vader breath with the peak and plateau pressure and the alveolar pressure shown. But we can also make the vent decelerate and look like a pressure breath. Here, I've circled the F so the flow is fixed. And it's computer driven. You can pick the tidal volume and it'll make that area under the curve, under that triangle, 500 mils, or whatever you've decided to pick. And the pressure is still variable, but it'll look different. And it'll look very similar to how a pressure breath appears. But in this case, the flow is fixed and is not related to patient compliance or effort. The patient gets the flow that you've set no matter what. And their compliance or effort will simply change the pressure that's there. We'll talk about why decelerating flow breaths are quite useful sometimes in a few minutes. All right, so if we put these concepts all together and say that you are doing a bronchoscopy in a patient, what type of breath would you pick? I say mode here, but I really mean breath. Would you pick a pressure breath or a flow breath? Well, I've shown a picture there of the trachea down to an alveolus and an endotracheal tube in pink. And if we zoom in really close and you know you have a bronchoscopy scope in, or say you have an uncuffed endotracheal tube and you have a big leak, something that's making you leak to the environment, you know that it's going to leak upwards and it's going to go downwards. So you're going to have air that gets to the alveoli and air that goes up. If you pick a flow breath, you have a fixed amount of flow, and that vent will deliver 500 mils no matter what. Some will go up, say 200 mils, and some will go to the alveolus, say 300 mils. But that's it. That's all you get. You get 500 mils, and it goes where it is easiest to go. It will always flow downstream to the most compliant area, in this case, out to the atmosphere. But if you pick a pressure breath, the flow will vary based on compliance. And in this situation, you have this leak. And that means the vent sees a lot of compliance. It's easy to push air out to the atmosphere. And so that big hole will look compliant and the flow will increase. And so the vent may deliver 1 liter or 2 liters. A whole bunch of air will go in. And you're still going to lose some, but it might not be 300 mils to the alveolus and 200 mils out. It might be 600 mils out and 500 to the alveolus or some other number. So when you have an airway leak, you want as much flow as possible, and the pressure breath is the way to get there. That's the types of breaths, 2.5 types of breaths, and that explains every mode of ventilation we use. Let's go through the modes of ventilation.